Okay, we're joined by Craig Comrie. Craig is the Chief Executive Officer of Profmed. Hello, Craig.
How are you?
Good.
Good.
Profmed is a medical insurance company, and you deal mainly with professionals, doctors and accountants and people like that. Is that correct?
That's right. We have 35,000 professionals currently, so,
Okay.
and growing every month. So
One of the big issues that is going to affect your industry going forward is this national health insurance. South Africa is intending to adopt a national health system very similar to what they have in the UK, not in the United States, but in Europe. We're adopting the European model. Is that correct?
I guess the issue is that there is a number of different models, and so when you talk about national health insurance, you really have to look at the detail to understand what model is out there.
Okay.
Certainly the national health insurance model that's suggested here is not present in a lot of the countries you've just mentioned.
How is that? How is this going to differ? The one in South Africa?
So the one in South Africa, as a first principle, which we have a big concern with, is the fact that it ensures that a set of national health services can only be given from a national health fund. That means if you have the money to do it outside the fund, you cannot do it because of some of the amendments that are suggested in the bill.
If who has the money to do it outside? Just
So
differentiate
typically, if you take an income earner under a National Health Insurance Act, they would be paying taxes towards a National Health Fund. They can then access services within the fund. What they can't do is access typical GP type of primary care outside the fund. So in an NHS environment, if you have the additional
NHS
funding,
being the UK system.
the
Yeah.
UK system.
Right.
If you have the funding and if you have cover with one of their medical insurance businesses, you can go outside the NHI and procure those services.
Okay, here you're going to be locked into a government-provided service.
Yeah. And the amendments suggested in the bill are both on the medical scheme that you belong to, will not be able to provide you the national health set of benefits, and also the doctor, in terms of the Health Act or the amended Health Act, would stop a doctor from giving you that service as well.
Right. Now, what does that mean for your business? Is this the death of private medical insurance in South Africa?
Well, I think we're looking at it and saying that absolutely the agenda to improve healthcare for all South Africans is important. We need to be able to do that, but we do need to build an opportunity for people to exercise their freedom of association and their freedom of choice. If I can procure services out of my own pocket after I've paid all my taxes, then surely that should be allowable as well. So we also reference one of the parts of the Act that actually indicates that medical schemes will be around for the long term. So and the reference is to what is referred to as complementary benefits. So complementary benefits are the benefits not offered within national health.
You think this is a work in progress? It's going to develop and change and mutate as time develops when they see the limitations of trying to deliver to a country of 55 million. There's also been discussion about medical tourists coming to South Africa from Congo and Nigeria and places like that, and they walk into the hospital, they don't get turned away, but it is a burden on the state.
Yeah, look, the funding debate is the biggest debate. I think you can try buy a car, but if you don't know how much you have to start off with, it makes it very difficult to limit what your choices are. And so it will change things, and the health system has to change. Both the public and the private sectors have issues, and sustainability issues as well. So we have to work through that, and I think the answer lies in the togetherness. So it's a South African thing. We need to do some of these changes together to actually achieve the right outcome. So I think there's...
Are you engaging with government on this?
Yeah, there's lots of engagement, and NHI is not a new policy, so it has been around for the last 10 years. I think some of the frustrations that are coming through is that there's been very little movement in terms of that policy since it initially was raised 10 years ago. So after 10 years of consultations and submissions from the private sector, there has been very little give from the policymakers.
There was a TV program on quite recently, we spoke about it just before we went on camera, where it's Dr. Nicholas Crisp, who is going to head up this NHI. And he raised this example of somebody who needed dental work, a friend of his, and they were quoted 30,000. He went to another dentist and he said the guy can do it for 1,800.
Yeah.
That's a huge difference. The point being that when you're not measuring outcomes, it's like everything is itemized. You need a suture, you need this medicine, you need syringes and all that kind of thing.
Yeah.
The incentive is just to load that bill.
Yeah.
There's so many weird incentives in the current medical system. Do you not agree that this can be much more efficiently done? And the government has a point.
The government does have a point in terms of what we pay in private healthcare for our services, and I think what is very difficult to do is empower an individual to actually bargain or get a better price out of his doctor who he's inherently trusting. And I think sometimes that balance of that relationship is skewed.
Right.
So the medical schemes have for a long time fought to try and empower the individual to actually do some shopping around for the best quality of service at the best price. So exactly what Nicholas has done is what we try and educate our members to do.
And have you ever got anything like a reduction in price that he was talking about?
Our members get it quite frequently.
Really?
Yeah. I think he's used quite a surprising quote and service with a dentist, but it shows you how diverse some of the pricing is in the marketplace.
Yeah. Okay, one of the things that hasn't really been discussed or thoroughly discussed is the cost of this NHI. I mean, it has been spoken about in fairly histrionic terms that it's going to bankrupt the country. It's another ESCOM. It's one of these boondoggles that's just going to kill us. Is that true?
I think it's a bit of fear-mongering, and because we don't know what is included in the NHI package, it's very difficult to determine what the budget is. But it has been the one missing link in terms of what the policy or what the bill has said. What it has said, it says how you would fund it. So without thinking of how much it may cost you, they're talking about how you would fund that. And that
right,
would be,
just explain how it is going to be funded.
Yeah, so there are a few aspects that they're looking to fund it. The first would be something called payroll taxes. So for every rand you would spend in terms of salaries and wages, you'd have to give 2% to the NHI fund, and that's across
over and above the 1.5 you're already paying, for training.
The skills development levy.
The skill development levy,
Yeah, this would be an earmarked tax for the NHI fund, though.
Okay.
They are talking about additional taxes on individuals, so to supplement it even further, another probably 2% for individuals to come through. And so a number of then interesting funding mechanisms like donations and other. Sounds quite odd.
Don't know how that's going to work.
But the gaps could be extensive, and I think our concern is already we have quite a small population of taxpayers that fit the bill for the whole of the health system, both the private and the public. So there's about 220 billion rand in the public sector and another 230 billion in the private sector. But both.
So that comes to about 460 billion per year.
Yes.
To fund this thing.
Remember,
where on earth is that money going to go? Huh?
It's a fund, and I think
the agenda
is
but
to
but
put
it is an
that
extraction
together.
out of the economy.
Absolutely.
What?
How's
that going to work?
Yeah, there's lots of theories to say, look, the more you create earmarked taxes or you tax already a very small group of people, the less tax you actually get in the end. So the higher your tax rates, in actual fact, it's counterintuitive, but the less taxes you actually
but I think
collect.
in practical terms, if you look at the experience overseas, anywhere where you have a medical system, a public-funded medical system, this is the eternal fight, is how do you fund that thing and how do you keep expenses down? And this debate is never going to go away.
Yeah. And I think that's the main reason for where the even NHI is set to be implemented in 2026. I think the funding and the budget and the economic growth all has an impact on that timeline, and so I really project that will happen over a much longer timeline than is planned.
So it'll start off with like providing basic medical care, which you already have, of course, through the clinic. So it's really a reallocation of funds that are already being expended on the same thing, maybe adding a little bit on top. Seeing how that goes before. I don't think this is going to be a radical rollout. You know, we're not going to flick a switch from one day to the next.
I agree. I think it's going to be slow and steady, and mostly because the funding is a big question.
Right.
So you can only get what you can pay for.
Yeah.
And so one of the initial movements we'll see is what is called the tax credits, which allows a taxpayer to claim a deduction if he belongs to a medical scheme currently.
Right.
And so the first target is about 25 to 30 billion rand that sits in that space. So to add that to a national health insurance fund is a start in terms of the funding movement.
If you were given a blank piece of paper, how would you design this?
Would be very difficult. I think you would have to do it slow and steady. I think that's the way to do it.
So the way they're doing it is pretty much correct.
I think so, and I think what you have to do is look through all the political noise and see what practical is implementable.
Right.
I think that's the real trick to this whole thing.
Okay. Do you see a future for your company and others like you?
I think there's still a bright future.
Bright future.
In the medical scheme space. I think the scheme industry has, for the most, taken the burden off the state for almost 15 million people.
Right.
So already that's not a burden the state has to carry.
Right.
So I think better has to be done in the public sector, and the private industry has to contribute, and each individual South African is going to have to contribute on how that will work.
How many people are covered by private medical insurance in this country?
So we have about 8 million people covered by private insurance.
And the rest therefore are wards of the state?
That's how it works.
Which, you know, is like pretty much 50 million.
And it's the inequity that is the problem. And there's no doubt there is inequity in that. I think the inequity isn't just caused by the funding issue. I think it's caused by the lack of accountability in some spaces and the inefficiencies that exist in the public spaces and some of the private spaces.
Yeah, I mean, there was very little in the way of private medical care, you know, back in the days. I remember when my kids were being born, they were born in the Joburg public hospitals, and they were pretty decent places, you know. Yeah. I suppose you were too.
Absolutely.
Yeah.
So there's a sideline debate and say NHI has always been in place.
Yeah.
And this is just a different way of procuring what is quite well-funded private sector in terms of funding the inequities that we see in the state space.
There's been a lot of discussion about, you know, what are the optimum funding mechanisms for healthcare. It's not a debate that I've ever seen anything resolved. In fact, it keeps on changing. They would talk about medical savings schemes at one point. You know, it was a kind of self-insurance, which I'm pretty much in favour of, because anything unspent, you know, you can carry on. So, and it does kind of encourage you to look after your health.
To save.
When you pass that on and you socialise the cost of your ill health and your poor moral judgments or whatever it is that you make, that then becomes a burden on society. And this, of course, has been looked at in all sorts of ways around the world. I remember the Chinese discussion about the Chinese doctors only getting paid when you're well. I don't know if that's true or not.
That's interesting. I haven't heard that version, but there's no doubt that there's a huge space to discuss how do we keep the country well. There's a growing burden of disease countrywide in terms of diabetes and lifestyle-related issues. I think we've actually done quite well in terms of the HIV programs over the last 5 years, 5 to 7 years, and I think that's been one of the huge successes.
You don't hear about it anymore, right?
So if we approach NHI or even improving access to healthcare for everybody in South Africa in the same way, I think we could actually change quite a bit.
Right.
I think that would be off the space where you don't have to over-regulate the industry. You don't have to nationalise an industry to get it to change. Yeah.
What are the big health issues? I mean, where's most of the money getting spent these days?
That is the lifestyle-related diseases, so hypertension, cardiovascular-related illnesses, diabetes.
Which are preventable.
And so a lot more initiative has to go into promoting exercise, healthier living, dietary related issues. And this is in a space, and the dichotomy is it's in a space of where people are fighting to survive.
Right.
So there's a real balance that has to be achieved. We have to do better.
Yeah. Craig Comrie, Chief Executive Officer of Profmed. We're going to leave it there. Thanks very much for talking to us.
Great. Pleasure.
Okay.